Hello, welcome to For the Young at Heart. My name is Lucille Jerome. We're sponsored by Duval Life and Wellness Community. My guest today is attorney Ed Adamsky. He practices in Massachusetts. We're going to be taking a look at advanced directives, the healthcare proxies, the 5 wishes, which is something new, and something else called the most. Without further delay, thank you for coming, Ed. There's so much going on with the advanced directives.
Thank you for having me, Lucille. Happy to be here.
Yeah, well, we talked once before, several years ago, so a lot has changed since then.
Some things have changed, some are still the same, so you have to know what's what.
Well, what's what?
Well, the big new thing is the MOLST that you mentioned, which stands for Medical Orders for Life-Sustaining Treatment. It's not a substitute for the healthcare proxy, but it's a new protocol in Massachusetts that allows medical orders to be issued that can follow a patient from facility to facility and state the patient's wishes for certain end-of-life type care. It's only for patients who have a severe medical condition that is likely to be terminal or is very serious, and so certain severe end-of-life care.
So it's end-of-life mostly?
It's mostly for end-of-life.
Okay, but it's not a living will?
It's not the same thing as a living will, although in some ways it's similar, but it's really medical orders. So it's a physician's orders of what treatment should be given or not given.
It's a real doctor's order is what you're saying?
It's a real doctor's orders, yep.
Okay.
It's
it goes with the person from the hospital to any other facility?
Correct. It's medical orders can be put in the patient's medical file at a facility, but the patient can get and should get the original of the document to carry with them and take to another facility. In the medical orders, there is a do not resuscitate or resuscitate. It's the patient's choice. There's intubation or not, or ventilation, and there's hospitalization or not. Those are the major orders that are in that form, and the patient, along with the doctor, decides which should be done, puts it in writing, and then that's a valid medical order that can follow the patient and will be honored by most all medical facilities and emergency medical technicians as well. And the patient's wishes can be fulfilled.
Okay. Where did this come from, the most? Where did it originate from?
I think it originated out west. I think maybe California, although I'm not positive on that. I'm afraid. It's been around for a while. I think since the 1990s, I believe it was first conceptualized.
Okay.
I mean, do not resuscitate orders have been around for a long time. Those are our medical order. The patient and the doctor discuss, should you resuscitate it if you suffer a cardiac arrest? For most people, the answer is yes. Of course, you want to be resuscitated. For some patients with a very serious terminal medical illness, they may not want that extra treatment. It would only prolong their life maybe a little while with extra pain. So, so the concept of do not resuscitate has been around for a while, but it doesn't cover everything. Cardiac arrest is not the only thing that happens to a patient. So sometimes patients stop breathing. Should they be intubated or given ventilation or not? Sometimes patients suffer, they have a medical condition and they suffer some event, but they're at home. Should they be taken to a hospital or not? The patient might want to just stay home, even if it means they're not going to survive. They'd rather stay home. I've known many people who really wanted to die at home rather than in a medical facility. But that means you have to take some drastic measures to say, no, even though I'm lying there on the floor or something, don't take me to the hospital, which is a difficult thing and hard for people to understand and follow. That's why a written medical order that says do it this way, signed by the patient and by the doctor, is something that can fulfill the patient's wishes no matter what.
Can you almost look at it as an expansion of the DNR, which was a doctor's order?
I think so.
So this covers the other pieces of the puzzle.
I think so. It's an expanded do not resuscitate order, or a DNR plus, perhaps.
DNR plus. Okay. But there's also something else called 5 wishes.
5 wishes is a type of healthcare proxy. Let me talk about healthcare proxies. In Massachusetts, and pretty much everywhere in the United States, every patient is allowed to make their own medical decisions. Doctor says you can do A, B, or C. The patient gets to choose A, B, or C. No one else gets to choose but the patient. The doctor gives recommendations. Family members could chime in their opinions, but the patient makes the decision about what medical treatment to receive. The trouble comes in with medical care is that the patient might not be able to express their preference. They might be unconscious or mentally incapable of expressing a preference. What do we do then? For a while that was a problem until someone thought up the concept of naming a healthcare agent and giving them the legal authority to make that decision. Now most states, I believe all 50 states, have enacted some sort of healthcare proxy law that allows a person to name another person to be their healthcare agent who will have the full legal authority to make the medical decisions for that person if the person is incapable of making his or her own decisions. So
Key word, if the person cannot make those decisions, right?
And
some people think you can automatically make them.
That's true. The patient is always presumed to be able to make his or her own decisions.
Right.
Unless and until that patient's doctor says, this patient cannot make his or her own decisions. I can't talk to him. He doesn't understand me. It's clear if the patient's unconscious, of course they can't make decisions. But short of unconsciousness, there could be patients who can still talk maybe, but their mind isn't working right and they can't really make an effective decision. At that point in time, the doctor notes that down in the patient's medical record, and the medical people call that activating the healthcare proxy. So if there is a healthcare proxy, then from then on, and unless the doctor determined the patient regains the ability to make healthcare decisions, from then on the medical people will turn to the named agent in the healthcare proxy to make those decisions. So in Massachusetts, we call it a healthcare proxy. Some other states call it a power of attorney for healthcare or an advanced medical directive. There's lots of words for them. A lot of people call it a living will, but that's a little different. So the first thing in Massachusetts is you should have a healthcare proxy. And everyone should have one. Anyone over 18, they get to make their own medical decisions. They might have a situation where they can't make them. They need a healthcare proxy. It's just a piece of paper. You keep it in a book or a box or a file somewhere. Hopefully you never need it, but it's kind of like an insurance policy. If you ever need it, there it is. Your named agent can make your decisions for you. In the document, you can name your agent. You can name an alternate agent. And it has to be signed by the individual, and it has to be witnessed by 2 disinterested witnesses. And so that's when you mentioned the 5 wishes. What's the difference in the 5 wishes? Well, the standard healthcare proxy in Massachusetts is a pretty bare bones form. It's 1 or 2 pages long, and it says, if you fill in your name, you fill in the name of your chosen agent, you fill in the name of the alternate, and you sign it, and 2 witnesses sign it. And that's about all there is to it. There's some references to the state law and how it's going to work, but it doesn't say a lot of extra stuff.
You can write it in if you want.
You can add it on a 2nd or 3rd page. There isn't really room on that. I think there's a little room on the standard hospital form, 2 or 3 lines, but it's not a lot of room.
That's not a lot of room.
So the 5 wishes form was created by, I think, a consortium of some hospital people or other medical and ethical professionals, and it tries to expand upon a standard healthcare proxy to include a lot of things to think about. Care decisions, not just medical care, but physical care. Do you want to be at home? Do you want to be in a hospital? Do you want music playing? Do you want flowers in your room? Some things like that. So the 5 wishes is a way to, the form itself walks people through some decisions, some things to think about that expand upon just medical decision-making and into care at the end of life. So that's a good thing to think about.
It's more expansive than the healthcare proxy itself because you have the discussion. You're having the discussion.
Right.
And if you follow along with it, you're going to cover pretty much everything of importance to a person.
I think that's the good thing about
it?
something like the 5 wishes, is that it gives a format to have the discussion. And that's what I always tell clients, is that the biggest thing beyond getting the healthcare proxy signed and witnessed so that it's in effect is having a discussion with your family members, your named agent, your named alternate agent, and any other family members who are concerned, you should have a discussion about how you feel about various medical treatments and non-medical issues like
Right.
music in the room or something like
That's
that.
right. Important. For some people, that's very important.
It can be.
Some people, they might want a religious person in the room with them, or they might want their pet,
Correct.
a pet dog or a cat.
Yep.
You know, those social characteristics are very important.
Yep, it's very important. I had a client who wanted to be with her dog, and she was able to remain at home, and her dog was on her bed to the very end, and it was what she wanted, and it was very sweet.
Yeah.
So it's
I remember somebody, Ed, who had a favorite painting, and she wanted the painting in the room with her, and it was situated so that from her bed she could see that painting, and that brought her peace.
Right.
So-
Those are the sort of things
Yes.
beyond basic medical decisions that need to be discussed to help make whatever end-of-life situation there is as good as it can possibly be.
Right.
And that's the key to all of this advanced planning, is that we don't know what the future holds. We don't know what medical situation will arise, but we try to plan the best we can for whatever's coming to make it come out as best we possibly can.
As best as possible.
Right.
Many people still think of this as a morbid discussion to have, but it's a realistic discussion. What's morbid about it? What do you think that piece is about? I mean, you've been in the field, 20 years or
20
more?
years, yeah. Most people don't like to talk about death and dying. It's just not a pleasant thing to talk about. Oddly, I talk about it almost every day with my clients.
That's right.
I don't like to think about it either in my general everyday life, but it is something that should be discussed, especially if someone is ill. If someone has a serious medical condition, especially if one that might be terminal, then it's going to happen. It is going to happen for everybody, I guess. So
You
it's,
guess. A little levity.
seems to be so far. So you have to, if you want it to be as good as it possibly can be, you should discuss it ahead of time. I found the people who didn't have any discussions and don't know anything, it's harder. What do we do for Mom? We don't know what she wants. She's unconscious in the hospital. Should we pull the plug or not? We never had that discussion with her, so we don't know. That's a big problem.
Right.
If the discussion had been held, then the decisions would be easier. So it's really making things easier for everyone, so everyone understands the wishes of the person who is dying, and that those wishes are fulfilled as best as possible.
It also could possibly prevent a lot of family conflict,
It absolutely.
okay, which is terrible. It's such a time.
There
to have
can be a
such
lot of
conflict.
family conflict when someone is ill. It's a stressful time for everyone, especially stressful for maybe people who kind of out of the picture. I've often found in a lot of families there's a child who lives nearby who's the named healthcare agent, and there's a child who lives across the country who might be the secondary agent, but also might not even be named on the document. And that faraway child is often very anxious and feels left out and feels like they don't belong, they're not part of the decision making, and that's hard on that child. So it needs, that sort of thing needs to be discussed, and the concept of having a family discussion.
Right.
I usually tell people, just because you name child A as your agent, child A shouldn't just make decisions all by herself. She'd discuss it with
Yes,
child B,
very,
C, and
very
D if at all necessary. Now, legally, she doesn't have to. If the person is named as the agent, she gets to make the decisions, but they shouldn't be made without consulting the people who should be consulted.
There are other people who care. They care, and they might have different opinions. All the more reason to have that discussion before a serious illness.
Exactly,
All the
yes.
more reason,
Yeah.
especially for the person who might be across country, because I can see the other side of the coin, that they come and visit and they want everything done, even though they might have had a different discussion in the past, but because they haven't been kept in the loop, so to speak.
Exactly, I've seen that happen too, right?
Okay.
The faraway child shows up and starts to issue orders or say how things should be, and those
Yeah.
things are different from what the person really wanted, so.
It's a very emotional time. How can it not be?
It has to
How
be.
can it
It
not
always
be?
is going to be. But I think the emotions or the stress can be reduced if it's talked about ahead of
Yes,
time. That's the whole
yes.
key to advanced medical planning.
Yes.
The MOLST or healthcare directive is that in one way or another, you either talk it out loud or you put it on a piece of paper or somehow you write down or communicate your wishes to others so that when the time comes, there isn't a fight or a confusion. The right thing can be done at the right time and the process can be as
Right.
nice as possible.
Where would someone get these forms? Now, you're an attorney, so you have forms in your office, but not everybody will go to an attorney. I've seen people pick up healthcare proxy forms in a senior center, for example.
And those are perfectly fine.
Those are fine, too.
Almost all medical facilities will have forms available. A lot of senior centers will have them available. You can find them on the internet. You can just search for healthcare proxy and you can pull out a
And then you
form.
can pull it
The 5 wishes can be found on the internet, or you order it by mailer. So they're fairly easy to find, or you can go to an attorney and have the attorney help you prepare one. As long as it meets the state law, it's valid. And the basic rules in Massachusetts are you name yourself, you name the first agent, you name an alternate agent. It has to be signed by yourself, the principal, and it has to be witnessed by 2 disinterested witnesses. It's not required to be notarized in Massachusetts, although
Okay.
I routinely notarize the ones for my clients just
Sure.
because it's extra.
Okay.
In New Hampshire, they did change the law recently. It can be signed by 2 witnesses in New Hampshire, or just a notary or justice of the peace.
Okay.
I recommend my New Hampshire clients have it witnessed by 2 witnesses, just in case they come to Massachusetts.
I
I
was
wouldn't
just
want
going to
Massachusetts
ask you
to.
that. What if someone moves out of, so what if a resident of Massachusetts has done everything right? They have their healthcare proxy, they might have even done the most, but then they move to maybe Missouri or Florida. Are those things legal across state lines?
They should be. Most states have a provision in their law that says a validly executed healthcare directive from another state will be accepted in this
Okay.
state unless it's counter to state law in some fashion. And Massachusetts law says that, New Hampshire law says that, and I
Okay.
believe all 50 states have some sort of reciprocal agreement. So that's fine if you were just traveling to Florida for a vacation.
Sure, okay.
If you actually moved to another state, I would highly recommend you go see an attorney in that state or find a local form and do the local form, because there could be a difference.
Okay.
I mean that leads me to talk about New Hampshire. The New Hampshire Healthcare
Yes.
Directive is significantly different than the Massachusetts one because the New Hampshire law is a little more particular.
Okay.
The New Hampshire law requires a certain format for the document, and there are certain questions that are on it that have to be answered with a choice and the choice initialed. Otherwise, certain things can't happen.
Back up just a little bit. So they have specific questions that have to be answered, and you're checking as you go along?
Correct.
It's not legal if these things aren't done?
Well, like the Massachusetts document, it has your name, it names your
Right.
first agent and your
Right.
alternate agent. That's effective.
Okay.
But there are certain questions about terminating or stopping life-sustaining treatment.
Okay.
And if you don't choose, yes, my agent can stop life-sustaining treatment, then your agent cannot. There's a question about artificial nutrition and hydration. Should I be given it, or should I, or may my agent stop it? And if you don't answer that question, your agent cannot stop artificial nutrition and hydration unless you've affirmatively answered that question. Except that's going to change. As of January 1st next year, that question is actually coming off of the document.
Oh.
They've, for years, it was a separate thing. You had to specifically say that whether you wanted to stop artificial nutrition and hydration or not. And it was a very important thing in New Hampshire, but they have made it a little simpler and included artificial nutrition and hydration in the definition of life-sustaining treatment so that there does not need to be a separate question about that anymore, starting January 1st of 2014.
Okay.
So those are the sort of things that change. One particular thing in New Hampshire is that sometimes you come into a problem with healthcare proxies because the wishes of the patient are always supposed to be followed. But sometimes a patient really is incapable of making decisions, but they're still capable of talking and communicating. And a patient might say no to something, even though maybe they don't really mean it when they say no, or they don't know what they're saying when they say no. Unfortunately, if a patient says no to some treatment, they can't be given that treatment over their objections.
Okay.
And that's a problem. New Hampshire has tried to address this problem. You can put a clause in your healthcare directive that says my agent may order treatment even over my objections as long as my doctor feels that I don't know what I'm doing by making the objection. It's a very tricky thing, and I'm afraid it's going to be litigated someday because I'm not sure whether it's really going to work or not. But it's something different in New Hampshire.
Well, then they might not need something called the most in New Hampshire if they're that specific.
They might not. They might not. But I think I like the most because it is a way to convey that information to medical providers.
Okay. We're going to be winding down shortly. I guess from my perspective, thinking as someone who wants to know everything under the sun, frankly, okay, they can get these forms just about anywhere. There's no real cost for them, most of them, right? If they go to an attorney, I can see attorneys doing a bunch of, do a will, do a financial power of attorney, and just doing a whole thing for somebody, which might be easy for somebody, okay? The most, I have to admit, I was a little bit confused about. I wondered, could it be changed? Can any of these forms be changed once they're done?
All of these things can be changed at any time. It's the patient's wishes and desires. A patient can cancel a healthcare proxy and say, I don't want that person to be my agent anymore. I want to do a new one and name a new agent. The most can be canceled by the patient at any time or changed by the patient at any time.
Right.
The most form can only be obtained through a physician, so it's something that the patient and the physician have to do together. The healthcare proxy, again, forms can be obtained anywhere. I do it as a package for my clients. We usually do a will, a power of attorney for financial matters, and then the healthcare proxy for medical decision making. And I charge a fee for all of those put together. So it usually makes sense for my clients to do them all at once.
Yeah. And you've been doing this for you've seen it all.
I've been in practice for 20 years. I've seen a lot of different things. It's true.
Okay. All right. In terms of, say, nursing home care, I think when you were saying something earlier about people who might be able to speak but might not comprehend something, are you talking about dementia necessarily?
Dementia is the most common thing. A dementia patient might refuse some medicine. It might be just their Tylenol or vitamin or something, and they might push the nurse's hand away and say, no, get away from me, I don't want that. And that's a problem because the facility cannot give the patient the medicine if the patient says no. So it can be a problem sometimes.
Suppose somebody doesn't have a healthcare proxy, and they are then very ill, and then they're on even maybe an antipsychotic medication or something like that. What do people do then? Is that beyond the scope of what we're talking about?
Well, what would happen is a court proceeding might have to take place. You might have to do guardianship proceeding, and the family members would have to go to court and see a judge, and the judge actually might make the final medical decision for the patient rather than the family members. And it's going to take time and cost money and legal fees, so it's highly recommended that you get a healthcare proxy done, no matter who you are or where you are, so that you'll never have to be in court with a judge you don't even know making medical decisions for you.
All the more reason to have it. It's not just family conflict. It's not just making your wishes known. There's also a financial piece to this.
Absolutely.
Without it, a stranger's going to be making decisions for you.
Right, very inexpensive to get it done up front. If you didn't do it, it's very expensive potentially to solve a situation.
Like I said, we'll be slowing down in a few minutes. What would you like most of all for everyone, our audience, to think about doing? We've already said do it, but other than that, what is very important for people to understand about this? Because this is really crucial. We're talking something very sensitive, but also very crucial.
Right. Well, I've said it before. I'll say it again. It's important to have the healthcare proxy document properly completed, signed, and executed so it's in place. Then it's crucial to have a discussion with the family. Everyone who's potentially concerned with the medical decisions or with the outcome should be in on the discussion.
In on it.
The holidays are coming up. The holidays is a great time, as odd as it may seem, to have the family together and say, let's talk about death and dying. It's the time when the family's together. It's a tough discussion, but it can be a good discussion. It can clear the air. It can really help people feel more comfortable about what is inevitably coming.
Right.
And it can avoid a lot of fights in the future. So that open communication, a good family discussion, and an expression of a person's wishes out loud to the whole family so they understand will make the whole process a lot easier when the time comes.
So even at a holiday?
I think a holiday is a great time. The family's
time.
together, sitting around, enjoying good times, thinking about the old days.
Let's go into the family room and let's have a cup of coffee and talk about life
and death. Yeah.
Yeah. I'm thinking, you know, I know that some people think of this as being a morbid subject, and we've already mentioned people don't like to talk about death in general. For something to be so serious and important, and to just let it slide for years and years and years, as though it's not going to happen, you know, that's the irony of it all.
It is. It's what people do. We don't like to talk about difficult and scary things. Doesn't change the fact that those difficult and scary things are going to happen. It's better to talk about them than not.
Better.
But
It's
we
even
all
better.
avoid discussions of scary things, and so you have to do your best and have the discussion. It will make it better if you have the discussion.
It really will. It really will.
It will be better.
I want to thank you so much for coming, Ed, today. And I want to thank you for watching. We've learned a lot. I feel less hesitant about the most. I really do feel less hesitant about that one. And it could be changed, as you said. Anyone can change it. You change your mind. People change their mind all the time.
Sure.
So they can change their mind. And these aren't expensive forms. And they're available in many places. So what's the possible excuse not to do it?
There's no excuse. It needs to be done.
Okay. Thank you again.
You're welcome. Thank you for having me.
Thank you.